think mental health practitioners have been extremely insecure, power-driven and mystifying, including me, in terms of guarding our territories and therefore saying we are the only people who can provide services. Today I really feel when I talk to a community worker, the way they talk to community, I can never master it in next 20 years of my life. So I would say definitely, who provides services, our definition of that has to be expanded immediately, right? And I also see a Brahminical hierarchical system over there where psychiatrist is at the top, then I'm there as a clinical psychologist, and community workers are here. Can we think of another system which is at the top, community workers? They are the ones who understand community, I don't. So I think who and how, right? So is it provided definitely through one-to-one? I think that is still the most favorite understanding of psychotherapy. You know, one-to-one talk. We can't think about painting. Somebody was saying, I think, wonderfully you said that, you know, it is not about dancing and movement. It could be just about, you know, sensing how you're feeling and how you're breathing. And I love that articulation. So how it is provided, it could be through songs, it could be through dialogues, it could be log just बैठ के बातें करते हैं. And I'm seeing many young people who are saying, hey, I don't want to start psychotherapy. I want to start a cafe, right? So I'm just saying that where mental health and how mental health services are provided is also very important to change. Yeah. So I'm now coming to the end, so you can start breathing also. But what is it that I'm saying in the end? That listening and building up rather than a top-down heavy approach, centering voices from the margin, lived experiences, and working alongside the community. So many times when people are presenting about their research findings or psychotherapy or testing, they say, I did research on somebody. And language itself is so hierarchically reflective that we don't say with, right? So I think we have to work alongside, forget about with, alongside communities, because they have great wisdom. They know what works, what doesn't work. And maybe you could be a facilitator, co-traveler, but I think very important. When you're working with marginalized communities, psychological solutions are not going to work alone, definitely. And there is a fragmentation between health and mental health services and social protection or social justice or social welfare services. And it's high time. So that's why iCall over a period of time, apart from training mental health practitioners, has started doing this. I really feel that mental health is a development issue, right? It's not just an individual issue. So wherever you are doing mental health services, can you also talk about ration card? Can you also talk about employment? Can you also talk about rights assertion? Can you also talk about safety? Can you also talk about protection against violence? And when you are doing violence programs or some other development, what are youth development programs, can you integrate mental health? And that is the only sustainable strategy in a country like India, where you expand mental health, and mental health will reach people wherever they are rather than them all rushing to the clinics. Therapy is not the, I've become humble enough through my own mistakes to understand, therapy is just one way of healing. Healing is a dirty word in objective scientific psychology. But I think somebody mentioned Bhargavi Davar, who was my mentor for 5.5 years. I had a privilege of working with her, and she introduced the word healing. So healing happens in multiple ways, including traditional healing. Many of you may suddenly start saying that अब तक ये औरत जो बात कर रही थी मैं agree करता हूँ या करती हूँ या whatever gender label you go with, ये वाला तो नहीं चलेगा. There is astounding and undeniable evidence in a country like India, and this is the resource that reaches people much more than mental health practitioners. So it's time that you don't teach traditional healers how do you actually look at depression symptoms and psychosis symptoms, and depression you handle, psychosis send to me, or major depression, you have to work alongside communities. It is not, again, creating knowledge hierarchies over there. Can I go to the next slide? Advocacy and social change. And I was asking, what does this advocacy mean? If I were to see you or me doing advocacy under the influence of social justice, marginalization perspectives, what would you be doing differently? So one is you will explore therapy as a space for identity, politics, exploration. How will you hold your inquiry and conversations differently? Advocating for the rights of the individuals. Sankeet was talking about disability, and I remember one of the clients of mine who had bipolar affective disorder. I used the Rights of Persons with Disabilities Act, and he's the only person in my almost 30 years journey who I know got a job. He was talking about 21 disabilities, and one of those disabilities, and he was from an influential family who finally managed to get a certificate, and he's a government official today under the Rights of Persons with Disabilities Act. So you have to advocate with schools, colleges, with organizations, employers, and families. In India, you cannot escape family. You hate them, you love them, hum saath saath hai, right? So you have to do something to advocate also with families. So how do you do that in therapy? Therapists participating in social justice movements, advocacy, helping communities to advocate for their rights, influencing policies, teaching, education, research as a site of advocacy, and influencing practice and ethics. You write. All of us are doing such amazing work. Like-minded people who are here should write and actually pass on some kind of practices and actually create counter narratives. It's not about hearing about people from the margins, but also people who are working with people from the margins. How are you actually carrying out that work is also a counter narrative that we need to start creating. Can I move to the next one? Next one. Unlearning and re-education, and I'm beginning towards the end because I'm a party to this whole enterprise called education, definitely. So I think very, very important. I heard a lot of critique, and somebody said that research project is a useless kind of a endeavor. And I'm seriously thinking that how will you have mental health practitioners who think about everything जो मैं बड़बड़ कर रही हूँ without actually being taught and exposed to this discourse at the beginning itself. And that's why I brought the beginning towards the end. That very, very important. And this is not done. I see a lot of young people talk the right language. So I feel that languaging has now become really, people are striving. But how do you live that language is the gap, and I know that people are sincerely trying. So you don't theorize here in head or on paper, but how do you translate that in practice? How is education? How is every class? So I teach a course called Personal and Interpersonal Development of the counselor or the mental health practitioner, in which if you were practicing or studying in some other countries, they are called multicultural competency courses, right? We don't have those necessarily integrated. And my solution is that that's like an achar. कि वो एक हो गया तो तुम्हारा सारा social justice agenda खत्म हो गया. It can't be. In every psychology paper, how are you integrating the agenda of social justice is equally important, including research which is supposed to be objective is what I heard. And this should provide some opportunities for self-reflection. I heard very nicely that it doesn't have to be an actual contact, it could be films, you invite guests, let people, and young people are fascinating. They come up with such good questions and they benefit the most from these dialogues. Can I have the next slide? So the last slide I promise that mental health in India and world is gaining prominence. When I started almost like 30 years, I'm very old, 30 years back, literally HIV counseling was the only funding that was available at that time for mental health counseling, right? No other mental health funder was ever thinking of this agenda, and people used to think कि ये कुछ तो करते हैं पर useless है actually mental health का काम करते हैं. Today I think we are really in a good space. COVID has done that magic trick. You can't say that it is their problem. It has hit everyone. So you can now say that, hey, I experienced some distress. So I think there are lots of opportunities for pushing the boundaries and centering and foregrounding voices from the margin. There's a need for research, dialogue. Last two things I want to say. While we are creating counter narratives, there is sometimes a danger for essentializing those marginalizations and counter narratives also. I hope I'm making sense somewhere, right? That the new normal of queer, the new normal of migration, the new normal of XYZ, then gets essentialized, and everybody has to fit into that queer identity, and then you get legitimacy, then you get services, right? So I just want to say that I hope it is an because that's where feminism lies. That's where critical psychology lies. That you build, you dismantle, you challenge, you create new voices. So I hope voices keep coming, voices keep challenging, and voices keep expanding and not shrinking, not essentializing. Last thing I want to say, anybody who is in this room who thinks like this is going to be pretty lonely in their life, right? They are going to be pretty isolated in their life. Many of you might have exited your WhatsApp groups, family WhatsApp groups, for the very reason, perhaps, yeah. You can't sit with them for food, you can't attend family functions, so pretty much a lonely. If you talk to other people, they will say, अरे बैंक में काम करते हैं यहाँ पर. This is a work which is really isolating, and sometimes it can make you question yourself.
मेंटल हेल्थ के लिए लगभग 1.5% बजट एलोकेट किया गया है, और वो भी पूरा इंस्टीट्यूशन के इंफ्रास्ट्रक्चर पे खर्चा हो रहा है. तो जब हम काउंटर नैरेटिव की बात कर रहे हैं, तो गवर्नमेंट की तरफ से, क्योंकि बहुत सारी कंट्रीज ऐसी भी प्रैक्टिस में है जो टोटल बजट के 10 से 15% खर्चा मेंटल हेल्थ पे और मेंटल वेलबींग पे कर रही है, और इंडियन गवर्नमेंट का फोकस अगर वहाँ नहीं है, तो हम गवर्नमेंट का फोकस वहाँ ले आने के लिए क्या स्ट्रैटेजीज बिल्ड कर सकते हैं, ये पहला. और दूसरा, जब हम काउंटर नैरेटिव की बात कर रहे हैं या अल्टरनेटिव प्रैक्टिस की बात कर रहे हैं, तो ये सब ठीक है, मतलब हम लोग ये सब करेंगे, करने की ज़रूरत है. लेकिन हम खुद जब मार्जिनलाइज बैकग्राउंड से आ रहे हैं, एक नया हमारे फैमिली को, हमारे कम्युनिटी को अपलिफ्ट करने की कोशिश कर रहे हैं, और इस कोशिश में पैसा जीने के लिए लगता है, तो फिर उस फाइनेंशियल मैनेजमेंट का हम लोग क्या कर सकते हैं, या उसके लिए हम लोग कैसी स्ट्रैटेजी बना सकते हैं एज ए इंडिपेंडेंट काउंसलर या मेंटल हेल्थ प्रैक्टिशनर, हम लोग क्या चीज़ें कर सकते हैं उसमें.
माय गॉड, ये बहुत ही आपने अहम सवाल उठाया है. आपका नाम क्या है? अजहर, या मुझे नहीं पता मेरे पास इसके जवाब है या नहीं. तो सबसे पहले तो जो आप बजट की बात कर रहे हैं, क्या बोलूँ मैं ये तो झगड़ा बहुत सालों से चल रहा है. जो पैसा है वो इंस्टीट्यूशंस पर इस्तेमाल हो रहा है. और अब अगर हमने एक बार RTI फाइल किया था, एक इंस्टीट्यूशन महाराष्ट्र में है, उनका बजट जानने के लिए कि जो पैसा उनके पास जाता है उसमें से वो क्या खर्चा करते हैं, तब हमें पता चला था कि 80% ऑफ दैट इंस्टीट्यूशन बजट इज ऑल्सो स्पेंट ऑन सैलरीज ऑफ द स्टाफ, राइट, एंड द रेस्ट ऑफ इट इज़ फॉर थोड़ा बड़ा जो आपको मेडिसिन ये वो देना है. तो और दूसरा अभी पेट पीव है हमारी सरकार का, जो टेक्नोलॉजी है. टेलीमानस भी बहुत चमक रहा है अभी, तो मेरे ख्याल से सरकार का ही प्रोग्राम है, नेशनल मेंटल हेल्थ और डिस्ट्रिक्ट मेंटल हेल्थ प्रोग्राम. कई कई ज़िले ऐसे हैं कि पैसा है पर वापस जा रहा है, क्योंकि काम करने वाले डेडिकेटेड लोग नहीं है, और कई कई जगह है पैसा आ ही नहीं रहा है. तो सरकार का रुख तो उस तरफ है कि कम्युनिटी मेंटल हेल्थ की, पर वो बजट एलोकेशन और भाषा इंस्टीट्यूशंस की, आप किसी भी ऑफिशियल से बात करो, वो इंस्टीट्यूशन की भाषा नहीं करेंगे अभी, वो DMHP की भाषा करेंगे. बट कितना लिखा गया है, कितने साल हो गए, 1995 वो प्रोग्राम आया, 2000 साल से तो एक्चुअली एक्टिवेटेड भी है, पर अभी तक अपार्ट फ्रॉम सम शाइनिंग आइलैंड्स इन द साउथ वो प्रोग्राम उतना चल नहीं रहा है अभी भी. तो हम दोनों साथ में बैठ के कुछ एडवोकेसी, ये पीछे आपके प्रीति भी बैठी है, वो भी काम करती है बहुत उस पर, तो हम लोग शायद मिलके कुछ इसके बारे में बातचीत कर सकते हैं. और दूसरा जो आपने सवाल उठाया, तो वो यंग लोगों के साथ या मार्जिनलाइज्ड कम्युनिटी के साथ आई डोंट हैव एन आंसर. और वो मैं हम्बली ये कह सकती हूँ कि ये बहुत बड़ा इशू है कि मैं अगर दूसरों के लिए काम कर रही हूँ, तो मुझे भी अपनी ज़िंदगी और अपनी फैमिली को साथ लेकर, और या आई एग्री विथ यू, एंड आई होप ऑल ऑर्गेनाइजेशंस आर सेंसिटिव टुवर्ड्स यू नो दिस, एंड इट्स नॉट कॉल, जो जो इस सेक्टर में आता है ना, वो सडनली सेल्फलेसनेस उनसे एक्सपेक्ट करते हैं. लीडर सारे सेल्फलेस नहीं होते, पर वर्कर्स सारे सेल्फलेस होते हैं, तो ऐसा नहीं चलेगा. आई फील कि मुश्किल है ये सवाल उसका जवाब देना. हम बात कर सकते हैं. आई थिंक सम एडवोकेसी विद इन द ऑर्गेनाइजेशंस इज आल्सो रिक्वायर्ड फॉर दैट. फॉर श्योर.
So one of the most common thing that I've faced in the field is people, whenever we are working, though we are trained in using psychosocial lens through counseling, especially when we are working in the organization in the field, the most common questions that I get it, but you are not a psychologist or you are not a psychiatrist. क्या आप हमारे बच्चों को दवा दे सकते हो? Like this was the questions raised by government schools and organizations. So thank you for bringing that up today, that there's a whole spectrum of mental health professional. It's not only about a psychiatrist or a psychologist. So I just wanted to know your thoughts of how do we navigate through all of this.
वो कास्ट सिस्टम है मेंटल हेल्थ का एक्चुअली. ऐसा मुझे लगता है कि ये कर सकते हैं, वो नहीं कर सकते हैं. एंड आई सीरियसली फील, मैंने ज़िंदगी में 25 साल पहले एक होम विज़िट किया था. मुझे किसी ने होम विज़िट के लिए ट्रेन नहीं किया था साइकोलॉजी में. तो एक सोशल वर्कर मेरे कलीग थे, उनको मैं लेकर गई थी और उनसे मैंने पहले ज़िंदगी में सीखा कि सो आई फील दैट ईच डिसिप्लिन हैज़ देयर ओन स्ट्रेंथ. एंड आई फील दैट maybe people look at psychologists doing XYZ competencies and social workers, but I really see that आप पूरा फैमिली काउंसलिंग और डोमेस्टिक वायलेंस का पूरा सेक्टर देखो आज भारत में, साइकोलॉजिस्ट वहाँ पर नहीं काम करते हैं, सारे सोशल वर्कर्स काम करते हैं. और कपल और फैमिली थेरेपी सोशल वर्क में पढ़ाया जाता है, साइकोलॉजी में नहीं पढ़ाया जाता है. तो इट्स वेरी इंटरेस्टिंग कि एक्सटर्नल एनवायरनमेंट और सिस्टम्स वाला काम सारा सोशल वर्कर्स करेंगे और इंटरनल सिस्टम्स और एनवायरनमेंट वाला काम साइकोलॉजिस्ट करेंगे. ये डिमार्केशन ही गलत है. तो I empathize with you, that's all. And
I'm a special educator and counseling psychologist. Over the decade I have worked with schools, then the development sector, and now I'm working with corporate sector. So now what I'm seeing is there is a huge trend of DEI there. A lot of checkbox activities been doing. It's easy to work with the operational band and sometimes managerial band, but where I am lacking is working with leadership team. When the leadership team very much aligned with DEI and they are themselves very passionate about this subject, then it's easy to work. It's wonderful. But recently I've heard someone saying that we treat everybody equally. You don't need to mention from which community you are coming. I myself comes from scheduled caste community, and then she stopped me saying that why you are even using it? I don't need it. I treat everyone equally. But I know it has an impact. There is no proper inclusion over there. So do you have something for me so that I can work with leadership team, because this is the point where I have to also limit myself. I'm a double advocate, and sometime I need to choose where to speak about it or not. So I'm struggling here.
And I completely agree, and a lot of appreciation that you're still working with that system. So I think it takes a lot to work in a difficult system. So I think you are doing everything that you should be doing. I think you are picking your battles. Because I think I was, when I learned about feminism, I was like somebody who was drunk on feminism, because I started challenging everything, and then I couldn't work with systems. Because systems are patriarchal, systems are oppressive. So I found my ways of joining but not getting co-opted, right? That is the balance, and I see you are doing that wonderfully. And I feel that the same person who says that why do you have to foreground to your identity, maybe there will be two more who would say I would like to hear more. Or if not this organization, you will find some other organization who will be in a, but I appreciate all the hard work that you are doing, and more power to you also. And I appreciate all the warmth that came my way. I appreciate all the power that came my way. I will go back feeling very rejuvenated and energized, and found my own counter narrative and found my own community also. So more power to each one of you. Thank you very much.
Aparna did it so beautifully and so well. It's really not to add, but just to maybe highlight a few things which remain with me, and I hope to share them with you as well. One is, of course, of creating counter narratives, and I think the word of caution from Aparna is much appreciated, to not essentialize counter narratives and create other structures of power only to replace what exists, and therefore to also know that the task of creating counter-narratives is also a task of great responsibility. When we care enough to critique, we might also have to stay long enough to talk about action. Otherwise, I do feel that critique can sometimes turn into a space that's rather, that there's a certain ease of being in the space of critique only and not respond to calls of action and push for change. And I also suspect that's one of the reasons why, since it's come up so much, that CBT is popular, because the focus is on the other person and not on a push for change within the practitioner. And I do feel that the kind of conversations we've had between yesterday and today raise a lot of possibilities for cross-movement solidarities. The 2 days, the conversations we have had have shown us that if we want to do advocacy and activism within mental health, there is no way that we can isolate or cocoon ourselves in only mental health conversations. Our worlds will have to open up, and it also actually allows us to create solidarities with other movements, because I suspect all of us do agree that other factors, structures impact our mental health. And to that particular point, I want to bring in what Deepa said yesterday about the kadwi dawa, the bitter medicine that she spoke of, that we all need to question structures, we all need to question ourselves. And I do believe that the kadwi dawa is necessary when the problem is so dangerous, when the structures and the violence is so pervasive. And Dr. Ambedkar did call it a sickness, in fact, this kind of inequality. And therefore the kadwi dawa, which also creates a certain discomfort in all of us. And Tashi also in the morning urged us to stay with that discomfort, and that discomfort as the space that generates newer possibilities, because counter-narratives cannot come out of thin air or shallow critiques. Counter-narratives are generated out of discomfort and rage. And to close my closing, I do say this at our trainings also when we are critiquing structures of sexuality, gender, and I believe it is applicable across. And there have been panelists who have talked about love. And what's so interesting is in the world we live in, we are trained to hate. We are trained to hate certain kinds of identities. No one has taught us to love. In fact, to love is dangerous, because to love means freedom, and freedom is antithetical to the status quo. The status quo is not going to encourage anything that creates freedom. And therefore, I do believe that possibilities of counter-narratives and care will emerge from a place of love for freedom, for the self and for others. Thank you. And
we have reached the end of the two-day conference, and on behalf of Team HSNCU, KC and MHI, I will be delivering the vote of thanks. I would first like to express my heartfelt gratitude for the support of our institutional heads, our allied leaders, Colonel Professor Himlata Bagla, Vice Chancellor of HSNC University, and Mr. Harsh Mariwala, founder of the Mariwala Health Initiative. They have set an example of a leadership that aims at providing the resources to marginalized communities to work towards equity and accessibility on terms that are relevant to them. It's a mark of such leadership at top levels that inspires more leaders to pave way for discussions that we saw for the last 2 days. I'm referring also to the steady and encouraging cooperation of our principal of KC College, Professor Tejasri Shanbar. Next, I would like to thank Professor Neena Pujari, Dean of Faculty of Interdisciplinary Studies at HSNC University and Head Department of Sociology at KC College, and Dr. Shruti Chakravarti, Chief Advisor, Mariwala Health Initiative, who came together to bring to life and plan the execution of this insightful conference. What started off as small yet impactful collaboration through annual lectures in the Gender Issues Cell certificate course at KC College has blossomed into an annual national level conference. Thank you, Professor Leena and Shruti, for all your hard work and dedication to making this conference happen. I would also like to express my sincere gratitude to Professor Rakhi Mehta, the head of Department of Psychology, whose enthusiastic and warm support has allowed for the department to be a part of this disciplinary introspection. My colleagues, Aishna from the Department of Sociology, Dr. Pooja Soni and Jay from Department of Psychology, Dr. Kritika from School of Performing Arts, Dr. Tina from the Department of Liberal Studies, thank you so much for making the organizing of this conference a smooth and fun experience. But collaborations like these expand your world, and thus, for all of us here at KC College and HSNCU, colleagues are not just the ones with the same institutional affiliation, but also the ones at MHI. Candice, Amalina, Prathamesh, Fiza, Anugraha, Uzma, Pooja, and everyone at MHI, including the interns, thank you so much for your patient understanding and cooperation. I have become used to our email threads. It's going to definitely seem odd to not see them for the next few days. I would be remiss if I don't thank Mr. Jeevat, Mr. Happy, and all of the administrative and support staff here at KC, and the additional support staff that have joined us from MHI to ensure a smooth and comfortable experience throughout the duration of this conference. But my deepest gratitude goes to the panelists who joined us representing communities and discourses that have been missing in mainstream representations of mental health. It is not easy to grapple with questions of mental health of marginalized communities and speak about them in an academic setting where a hierarchy of knowledge has been historically perpetuated by those with structural privilege. The irony of treating neurosis in context of a world which itself is spiraling into what I sometimes describe as a state of skids or psychosis is grim, but discussions like these give me hope that I'm not alone. I would also like to thank the audience for taking your time to join us and even participating in our exploration of new discourses whose possibilities put forth to us here by our panelists. Thank you.